welcome everyone. Welcome as people start to sign in. Looking forward to hosting today's HSPN monthly webinar for Ontario Health Teams on measuring equity. We're just a moment late in starting today, but we'll catch that up, no trouble at all. Welcome. Paul, how about you go to the opening slide and we can just ask people to sign in on the chat. Please make sure that you send your note to everybody and say hello. And where you're from. Let us know where you're joining from. Welcome, Wendy from Toronto, Kim from Hamilton from the Good Shepherd. Lovely to see you. Welcome. Kelly Kay from the BGLO, Jen Lake from Toronto, Cami from Belvedere, and now I see coming in quick and fast, Dean Valentine from Toronto. I'm so glad, Dean, you continue to come back representing patient's family. Grace from Toronto, welcome, Grace. Donna Tucker from West Perry Sound. Here's where we have people coming in from all over Ontario, from shore to shore to shore. Kenora, Mary from the mental health in Kenora, Ontario, way up in the north, almost closer to Manitoba than the rest of us. Guelph, Bethany, welcome. This man from KCA, welcome. So please come in, let us know where you're joining us from. We're very, very pleased to have everybody joining us today. Alexandra from Ottawa, Trudy from Middlesex, London. Adrian from Oakville. Remember to send your text to everybody in the chat box. Click on everyone and welcome. Aaron from Algonquin College in Ottawa. Wendy Jerry, welcome from IDS. Krista from Scarborough, welcome. I think we have an amazing lineup today, and we'll get to introducing everybody in just a moment, but we'd like to start off with an acknowledgement of our land and our welcoming. Paul, I'll turn it over to you.
So for the land acknowledgements here, so we wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many indigenous people from across the Turtle Island, and we are grateful to have the opportunity to work on this land.
We always like to start off with a poll and let us know if this is the first time that you are joining us. Have you joined us for an HSPN webinar before? Say yes, or if this is your first event, please say no. Over 100 people have joined us so far today, signing in this lovely Tuesday morning, fourth Tuesday of the month. We like to bring everybody together to talk about the Ontario Health Teams, and we have a great event planned today. And it is, wow, we actually are really attracting a little bit of a new audience today. So maybe if we could share those results back out. We're seeing that 40% of people are joining us for the first time. 60% recomers. Usually it's a little bit lower on the first event. So so welcome to many newcomers interested in our new topic of conversation around measuring equity. I'm really pleased that we're attracting a new audience today. We are really looking forward to today's event. And if we could go on, we'd love to introduce the team. We can take down the poll results. And just to introduce a tiny bit of today's event, Paul and we've had Paul co-hosting for a number and really leading this series on health equity that the Health System Performance Network is putting together for Ontario Health Teams. And I'm joining Paul today as we also bring in some international colleagues, Will Manners from NHS England and John Ford from.
Yeah, so okay.
Welcome.
Okay, go on, Walters, because just to let you know, Walters is at the airport, and if there's any interruption, I will just pick up from there.
I just saw that unstable network come up. So Paul, why don't I let you lead off for this, and we'll just
Okay.
join as best I can.
Oh, yes. So just to give you a brief bios of our presenters, we have John Ford, who is an academic public health doctor and senior clinical lecturer of health equity at Queen Mary's University, London, and he also works at the National Health Services in England. He leads a program of research examining what works to address health inequities and supports the national NHS England team in data research and evaluation. Then Will Manners works as a senior analytical manager for NHS England. He's based in the regional Northeast and Yorkshire team and leads on a variety of work areas, including health inequities. His role involves producing bespoke analysis for senior stakeholders within the NHS region and supporting them in using data to inform and improve decision making. And our final speaker is Jessica, who's a master's student in health services research program at the University of Toronto. She has a background in biomedical science and is currently working on a thesis which investigates the different approaches to health equity measurements under the supervision of Dr. Walters, Wodchis. So I thank my panelists to agreeing today to the presentations. So we will first go into the next pool, just to have a brief idea of you, like how knowledgeable are you about health equity measurements? Maybe choosing 1 if you're not knowledgeable at all, to 10 if you are very knowledgeable. Yeah, Walter.
Yeah, I'm so pleased today to have everybody joining us, and it looks like we have a lot of people have already participated in. So we could, people are still coming with a few polls about where they stand on this level of knowledge. I appreciate your stepping in there, Paul, and I will, I'll do my best. I'm not really at my usual cottage mountain location today, but I've taken the picture along for the ride. Okay, how about we show out and share our results today? And I think that it's we have a lot of people in this middle ground of being somewhat knowledgeable, and then a few people on either side, very few people at the kind of higher end of being very knowledgeable. So I think we have a really, for our guests today, letting us know that we have a pretty good opportunity to bring up the level of awareness and knowledge in our audience today. So I really look forward to having our opportunity. We're actually going to go with one more poll just before Jessica kicks off. And if we could bring up that next poll, the third one, lovely. Thank you. Very interested in knowing, where have you focused your efforts in relation to equity? We want to get a sense of the activity that's happening. If you have not yet have any specific activity, or if you're mobilizing your resources, if you've identified new data sources, are you actively using data to prioritize areas to improve equity? Or if you have some others, then let us know in the chat. Please join in. So you can let us know how active you've been able to be in moving forward with some use of data, because today we're really talking about equity measurement and our use of data in equity measurement. Linguistic equity. Thanks, Alan, for joining in with that to know about, because that's actually very, very important with the highly ethnic and culturally diverse populations that we have in Ontario. Being able to share and understand people's access to knowledge and information based on how we communicate with them. Okay, why don't we share out this poll? There are still people coming in, but for the most part, it's starting to slow down a little bit. So we see, actually, it's great to see that not very many people are in this not yet having activity. And a good number, well, just under half mobilizing resources, and more than half actually between the other categories of having identified data sources and actively using data. Great to see a quarter of people actually actively using data to prioritize areas to improve equity. So again, that gives us a little bit of a sense of where people are starting out from. So thanks very much, and feel free, we really want to have this active chat all the way through today about what you're doing and how you're responding and engaging with the material that's being shared out today. So we're actually going to start off with some of our ideas of how HSPN is thinking about moving ahead with new equity measurement. And Jessica Morgan, a student at ICBs, has really been looking into this and studying these international examples, as with the NHS, and helping us understand some of the best ways that we could advance the science in meaningful ways that are useful to OHTs around measuring equity. So I'm going to turn it over to Jessica, and maybe you can start us get this foundation of measuring health inequities. Thank you, Jessica.
Thank you for the introduction. So I just want to preface by saying that the purpose of quantifying health inequities is not necessarily to show that there are inequities, but to be a tool to monitor and report on progress towards improving health equity in the health system. So I want to start with the definition of health equity and how it relates to the measurement of health inequities. So health equity is when every person has a fair opportunity to achieve their full potential for health. And it means working towards eliminating disparities in health and the determinants of health. And disparities is what is key to measurement, since that is what we want to eliminate. So these are adverse and avoidable differences in health that are linked to economic, social, or environmental disadvantage or under-resourcing. So while we can't directly measure health inequities, we can measure inequalities that are related to social, environmental, and economic factors. So if we go to the next slide, I find it easiest to break health equity measurement down into three components. So the indicator or variable of interest, your equity stratifier, and your statistical approach used to quantify the relationship between the other two components. So each of these components requires a lot of consideration in order to ensure that what you're capturing is what you actually intend to capture. And this presentation is just going to focus on the third one, the statistical approach. So go to the next slide. So what HSPN has done in the past in the area of measuring health inequalities is report to OHTs on the ratio between the fifth and first quintiles of material deprivation of various key performance indicators. So here we have an example of alternate level care days expressed as a percentage of all inpatient days in the same period by material deprivation quintiles. The quintile 5 to quintile 1 ratio, as you can see, is 1.14, which means that the proportion of ALC days is 1.14 times higher in the neighborhood with the highest material deprivation compared to the neighborhood with the lowest material deprivation. So the Q5-Q1 ratio is good in terms of being a starting point. It is a simple measure, it is easy to interpret, and it gives a snapshot of what is happening, but it's only able to describe pairwise disparities. So if we go to the next slide, you'll see that what it doesn't capture is what is happening in these intermediate groups here. So this gradient that you'll see between the Q2 and Q4 quintiles, and is essentially ignoring a large portion of the population where important differences might be seen. So if we go to the next slide, I have a list of a few of the different approaches which can be used to measure health inequities. And this is not an exhaustive list of the different approaches, but these are some of the most common you'll come across. And the ones I want to focus on, if we go to the next slide, are the slope index of inequality, the relative index of inequality, and the index of disparity. So both the SII and the RII are regression-based measures which use a population-weighted linear regression where groups are given a fractional ranking from most advantaged, which would be given a rank of 0, to least advantaged, which would be given a rank of 1. The SII corresponds to the slope of the regression, and the RII is given by dividing the predicted value of the linear regression for the least advantaged group by the most advantaged group. So if I go back to the ALC example on the next slide, you will see that the slope index of inequality is 2.49. And this means that the effect of moving from the least material deprived neighborhood to the most is a 2.49 percentage point increase in the proportion of ALC days. Because the equity stratifiers are given a relative rank from 0 to 1, calculating the SII is really simple. So it's just given by subtracting the predicted value of the most advantaged group, so Y0 from Y1. The RII in this case is 1.15, and it's given by dividing Y1 by Y0. And the RII being 1.15 means moving from the least material deprived neighborhood to the most is associated with a 1.15 times relative increase in the proportion of ALC days. So here you'll notice that the Q5, Q1 ratio and the RII are approximately the same. And this is because there is a smooth gradient in these intermediate groups. But if we go to the next slide, we'll see an example of one where there's not a smooth gradient. So the previous slide was for all health profile groups. But if we look at just the moderate chronic health profile group, you'll see that the second quintile is almost 2% lower than the first quintile. And the RII actually reveals a greater inequity than the Q5, Q1 ratio. And this really underscores the importance of considering these intermediate groups when you're measuring health equity. So if we go to the next slide, both the RII and the SII requires us to rank the equity stratifiers from least to most advantaged, or sorry, from most to least advantaged. But what happens if there's not a natural ranking? So for example, if we want to look at racial disparities, in this case, you could use the index of disparity, and it represents the spread of an indicator's rate in select groups around the total population's rate. So if we go to the next slide, I'll show the index of disparity in terms of the ALC example again. And on this slide, you'll see the equation for the index of disparity. And what it expresses is the difference between the indicator's rates for each subgroup in the population and the average of the population as a whole relative to the average. So here, the average proportion of ALC days across all groups is 18.02%. And the average deviation that the subgroups experience is 4.48% relative to this average. I find it easier to consider this in absolute terms, and you can get the absolute index of disparity by multiplying the ID by the overall average. And this gives us an average deviation of 0.8 percentage points. So if we go to the next slide, for the ID, you can change the inputs to fit your needs, but the interpretation of the measure would just have to change accordingly. So here's an example of not all the groups in the population being considered, just those which have worse health or worse status of a health system performance indicator than the average. So in this case, the average deviation that the subgroups experience, and those are subgroups with higher than average proportion of ALC days, is 2.87% relative to the overall average. And this is an absolute deviation of 0.517 percentage points. This would be considered potentially more appropriate than the traditional ID for indicators of health status, such as mortality, because it doesn't imply the need to reduce the health status of the most advantaged groups in the population. For the ID, you could also use different reference levels other than the overall average, for example, the best performing group in the population. So we go to the next slide. This is just the interpretations I said written out for when these slides are uploaded for reference later. And then the next slide is just the last thing I want to touch on, which is the difference between relative and absolute measures. So the RII is an example of a relative measure, and the SII is an example of an absolute measure. Relative measures are unitless, which makes them more intuitive sometimes to interpret and easier to compare across time and different indicators. But they could wrongly suggest a larger effect size than there actually is, especially for indicators which have a low event rate. Absolute measures, on the other hand, allow for a more complete picture of the indicator under investigation, and they could be useful for institutions who want to know the actual amount of resources which are being used or which may need to be redistributed. It is recommended that when possible, both relative and absolute measures are reported, And in the case of the SII and RII, because they use the same regression equation, this should be relatively simple. So the next slide is my final slide, and it's just in conclusion, want to say that equity is not just about the difference in health between the most and least advantaged groups in the population, but about the pattern that occurs across all groups. That being said, there are benefits and drawbacks to both measures of effect, such as the range and ratio, and measures of socioeconomic distribution. A lot goes into selecting which is most appropriate to use, and generally depends on what your equity stratifier and indicators are, what your goals are, and also who your audience is. The best approach really depends on what is most important, and whether that is quickly and simply communicating a message, or actually investigating where resources might be best allocated to improve equity overall.
Thanks a lot, Jessica, for sending in. And I think Janelle probably actually spoke with a question that many participants today would have. Probably over 150 odd participants today is like, do I actually need to know the math here? And I'll say that you do not need to know, and everybody here doesn't need to know how to do the math, but we want you to help us understand what is most important to measure. And so a couple of the key questions here are, first off, there's two big questions I think that we're going to want to be able to resolve a little bit today and to continue the conversation. One is, are we interested in just understanding the gaps between the extremes? So I always say that if we're interested in population health, we're interested in moving overall population health and equity, which means the differences between those that are doing best and those that are having the most difficulty, the top and the bottom. Are we only interested in that gap, or are we interested in this whole understanding of how people, and you've highlighted that very nicely, Jessica, along the way, of some measures only look at the ends and some actually also look at the distribution along the way. The second question is, what are we interested in measuring? How do we want to quantify those? Are we interested in sort of relative changes? So we want to do 10% better, or we want to make up half the difference? Or do we want to know things in terms of like the number of ALC days that we have improved amongst that lowest equity group? And that has to do a little bit with which of the measures we use. So maybe Paul, just kind of bring it back a couple slides just to highlight this, and then we can open it up to like about one more there. Perfect. If you could stop there, thanks. So here's a really great example that Jessica had, where we see that it's not a perfect linear relationship over the distribution, as we have like material deprivation. So the people on the left side here have the lowest material deprivation or the best socioeconomic status. And you see they don't have the fewest ALC days. It's actually the second quintile of people between 20 and 40% in that range of the socioeconomic, that they actually have the lowest. And if we go up to the people with the greatest deprivation on the farthest right, that's the highest quintile of material deprivation. They do have the highest rates of ALC days. But you see that it's not a perfect linear relationship. So one way we can look at this is it just the ratio or the difference, the gap between the highest and the lowest? But you see that actually, and that's an important piece of information. And often, if we have a straight linear relationship the whole way, that's enough. But sometimes we don't. And for various reasons, there might be extra supports available, or there are other reasons people may be extended, more likely to be transferred to long-term care or other hospital settings, such that they're not having this particular measure, ALC days, and it's actually that second quintile. And so are we interested in this distribution along the way? That's the first kind of question. Do we want to capture everything or just the extremes? And the second piece is, how do we want to measure this? Do we want to measure 3.27 times, which is that distance, the rate of increase across the distribution? Or do we actually just want to know those endpoints? And do we want to be able to quantify it in terms of the number of days or the proportion of that gap? So that's kind of some of the questions that we have. So actually, I'll put it out, probably go down to the discussion questions again, and I'll put it out to all of our audience here to understand a little bit about your take on things, just before we turn it over to Will and see how this actually comes out, to have a sense of that. Are we interested in the gaps between the extremes, so the highest from the lowest, or are you also interested in understanding that entire distribution along the way? We are using, for the segments, we are using one of the elements of the ONMARG, which is the material deprivation index, which is one of the 4 components within the ONMARG. And that is actually, you're going to see, very similar to the social deprivation index that they use in the UK. And on many of our prior presentations, you'll see, in many of our prior webinars, you'll see that we use the material deprivation index in all of our work. It's a broader measure of socioeconomic status than just income, although it does include income. It is based not on individual data, but on area level. So based on the dissemination areas in which the people are living, we have this attribution of the ecological socioeconomic status of the neighborhood. So let's open it up, and the distribution across the quintiles being more informative, identifying gaps overall, and understanding, I'm gathering then from Kevin Babelich, increased ALCDs for the first quintile may not be a negative, might be able to advocate to stay in hospital better. So they may not actually be identified being guessed. There's the definitional piece too, of whether they're actually being identified as being ALC, or in the UK, the term for this is delayed discharge for our guests there. And it starts to open up these other questions, and to understand what are the causes for the disparities. And so really happy to see the chat just firing up now. Awesome. Arsha talking about liking to see the overall distribution all the way across home and community care, in terms of quantifying changes or improvement. And some of you may know that since the origin of HSPN providing indicators related to the Ontario health teams, in every indicator, so we now have about almost 29 indicators that we've reported out, 10 overall, 5 for subpopulations, plus the CQIP indicators, those government priority indicators that we have identified in every indicator, the ratio of the worst to the best, or the highest socioeconomic status to the lowest socioeconomic status, what that ratio is. So every time we say, here's your readmission rate, or here's your premature mortality rate, or here's the use of emergency departments for low acuity, we also say, here it is amongst the population living in the areas of highest material deprivation as compared to those neighborhoods of the lowest. And that's a very simple thing for us to report. But I'm hearing here and starting to read that people are thinking that some of understanding those kind of gradients along the way, and then overall gaps might be more sense is Trudy keeping that simple conversation, and then assigning the Lillian talking about how these assigning distribution to the geographical area doesn't mean all the people who live in this area share that deprivation. Correct. Yes, Lillian, that is correct. We don't have individual data here. The dissemination areas are populations of about 700, sort of 700 to 1,500 people at a time are in those neighborhoods. And they are not identical or the same. Everybody living in those few blocks that make up the 750 people or so are not all having the same socioeconomic status. Think about your neighborhood and the people who live on your street. They don't all share the same, but there is a bit of an area. And in fact, these area level measures carry weight beyond what the individual measure would be. So there's actually both are very important. And the area levels serve as a reasonable proxy for access to many other services, both health and social, that could be important to people, as well as talking a little bit about reflecting to some extent the people that live in that neighborhood. Great. And yes, acting on this necessitates identifying those characteristics once patients are in the hospital. And ultimately, that's really the key piece here, is that once we know there's socioeconomic status is an important factor, and it is an important factor not for all measures, but for some. So for instance, in our palliative indicators, the proportion of people that die in hospital does not vary a lot by socioeconomic status. It's an interesting finding. But our use of hospitals for ambulatory care sensitive conditions varies a lot. And we've seen, for example, also cancer screening rates to vary considerably by the neighborhood area. And so we start to ask the questions, oh, we're missing people. Well, let's prioritize in cancer screening those neighborhoods with high material deprivation. And that will help us increase and accelerate our ability to do cancer screening faster than if we just had a generic approach. And it also lets us say, what are the barriers? Maybe it's the operating hours, maybe it's the transportation, maybe there are other things that are, the whys. Kelly, to what extent material deprivation correlates with home care service provision? We could definitely look into that and what's available to people in terms of the services. So again, lots of opportunities for us to be digging and layering this an extra step deeper. Okay, I think it's really great. Keep the chat coming. And I would really like now, Paul, maybe you can turn it over and I'll leave you to help to introduce Will. And then we're actually going to see some live action in Will's presentations, which is like super fantastic. You're going to love seeing what they've started to do to support integrated care boards. And I'll say as a point of intro that the integrated care boards that will talk about are very similar in many respects to Ontario health teams in terms of having attributable populations. And they have already moved from integrated care systems to integrated care boards where they have formal governance with representative governance boards. And that's why they're referred to as integrated care boards. Go ahead and I'll continue to watch the chat.
Yes, you can go ahead, Will.
Great, thanks, Paul, and just put my camera on. So hi, I think Paul did a great job of introducing me, but yes, I'm based over in NHS England. So just going to talk some about the analysis we produce. So go on to the next slide, Paul. Just before going in, just to provide a bit of structure in terms of NHS England and how it works. So I work in a regional team, so we can see on the chart off the map opposite, there's kind of 7 regions. The North East and Yorkshire's in the kind of top right hand corner in the blue, and we have 4 integrated care boards within our region. So I guess our role as a regional team is really kind of very much, we sit in between national NHS England, who maybe are the teams who produce the main dashboards and do a lot of the high level oversight, and the ICBs who do the direct commissioning of services and are really kind of linking in with local authorities and other organisations. Our role, maybe we go on to the next slide, Paul, I think that's got a bit more information on, is kind of overseeing the kind of delivery of the health inequalities agenda across the 4 ICBs in our region. So in reality, this is pretty light touch in terms of what we do. So it's not like we're kind of, it's more helping identify spread good practice and seeing what we can do once that then avoids them having to do it 4 times each. If we can do something effectively at a region level, that saves them time and resource. So what we do as an analytical team is provide reports that give our regional program team a kind of high level view of how the ICBs are performing for key metrics. So they can then take those to quarterly meetings with national to just kind of summarize where we're at as a region, and they can kind of get that high level overview. So I guess that's the reporting upwards. Then what we also do is share these reports, or we will be doing very shortly, is sharing these with our integrated care boards, who will then kind of use the analysis. They'll have their own analytical teams who can take the data forward. Cool. And like it meant, so we'll just, and so before sharing the analysis itself, just to quickly mention, I think we've touched on this before, but in England, we I think have a very similar methodology to Canada to calculating deprivation scores. So it's an index of multiple deprivation methodology. So this looks across the 7 areas you can see opposite, so income, employment, etc. Bigger weighting given to areas like income and employment. And these assign from all these variables that feed into this, assign a deprivation score to each what's called lower layer super output area, kind of each of about 1,500 people in. So all those 1,500 people will have the same deprivation score based on the data that's collected. And so just for context, for our region, northeastern Yorkshire, so we've got much higher levels of deprivation than England as a whole. So we kind of, similarly to what Jessica was showing, put people into deprivation quintiles and deciles with very national deprivation quintiles and deciles, sorry. So we're very much overrepresented in people living in the 10 and 20% most deprived areas nationally. So we've got, say, post-industrial towns like Middlesbrough, where over 50% of the population live in what would be called the 10% most deprived areas nationally. So it's kind of addressing these inequalities is kind of very much high on our agenda as a regional team. Cool. So I might try and do something now I don't think it's been done before, but it worked when we tried it earlier, and that's to share my screen. So I'm just going to talk through some of the analysis that we've produced. Okay, so ignore this starting text here, but this is an example of a report that the ones I was speaking to earlier, that we'd share with national, kind of be used to report up to national how we're doing for inequalities, and then also share these with the integrated care boards as well. So the metric we're going to be looking at is cancer screening. So in the reports, so this was produced in the R data science tool. So we find this, you can use this to produce really nice interactive HTML reports. So it's we find it's kind of a bit nicer than PowerPoint, and they've got added layers of interactivity. And it also allows you to kind of, do incorporate narrative as well. And within the NHS, there's an NHSR community, which is kind of a community of analysts looking to use this more as a data science tool. It's open source, so freely accessible, and anyone can use it, kind of similar to languages like Python, if anyone's used them before. So within the NHS, so for cancer, we focused on cancer screening. So for the NHS, there's a big target around improving early detection of cancer, to kind of improve that to, I think, about 75% in stages 1 and 2 by 2028. However, the data that we have on that is only available annually, and it was last updated in 2020. So for our purposes, what we were looking at is, can we come up with an alternative measure that's more regularly refreshed? So in NHS, we can get access to monthly cancer screening data that's also a lot more timely than the early detection data. So what we do is, in the HTML document, we have 3 different tabs. So this first one, so in the NHS, they're very similar to integrated care boards, but we have what are called cancer alliances that essentially align with them, but focus exclusively on cancer. We have the 4 integrated care boards in our region, data starting in August 2021. I should say the data's on a rolling 3-year basis. So looking, everyone invited, aged 50 to 70, invited to breast cancer screening in the 3 years prior to that, to August 21, and showing what percentage were actually then accepted the invite. So what percentage were actually screened. So what we have is our 4 ICBs, and then England as the dotted line. So that would tell you quite quickly that, okay, 3 of the 4 are performing better than England, and we can see 1, Humber Coast and Vale, kind of has undergone quite a noticeable increase in that time as well. The next tab, then what we do is we show the slope index of inequality values. I'm very grateful to Jessica for already having done the legwork of explaining these, so I'm not going to go over them again. But just to say that, say, a value of 22 for West Yorkshire and Harrogate would show that the difference between the 2 endpoints on the line is 22%. So quite noticeable inequalities there. So that would mean if, say, actually, in this case, the data is aggregated up from practice levels. Say for practices in the most GP practices in the most deprived areas, if their values were, say, 60% who had been screened for breast cancer, at the other end of the line for the least deprived, it would be 82%. So kind of that is a 22 percentage point gap, which is obviously, yeah, pretty massive. And so that would be flagged as the outlier ICB in our region. We can see that their inequalities are greater than the others and also higher than England. I mean, to be honest, it's not really a great picture anywhere, but at least Humber, Coast and Vale and Northern have both, are at least noticeably below England. And I think what's interesting in having these two views is you can kind of put the two side by side. So for say Humber, Coast and Vale, we can see their overall screening uptake went up over this time period, but so did their inequalities, or the gap between most and least deprived. So that would infer that the kind of what was driving that increase in screening uptake were practices in less deprived areas. So a consequence of that overall improving performance has been widening inequalities, which is obviously a kind of quite an important nuance that you'd miss if you just saw the data just like in that format. So I think this highlights the value in bringing these two views together. And then finally, what we have are these, this is a quadrant chart. So what we do is we take the most recent performance data here. So from August, we take the most recent slope index values here. And what we do is we plot the performance or kind of screening uptake values along this axis and the slope index values along here. So that allows us to then we plot the England slope index value for August 2022, and then also the overall England screening value for that time period. So then that allows us to create these different quadrants. So here, these cancer alliances, they've got high performance, so they're above England, and their inequalities are also narrower. Obviously narrower here is a bit relative in that they've all got higher uptake in less deprived areas. It's just their gap isn't as big as England as a whole. So we've used the same colour scheme as before. So with Humber, Coast and Vale, the one who we saw who'd done well and whose inequalities were lower, that places it here. And then similarly West Yorkshire, whose performance was just slightly lower than England and whose inequalities were wider, that places it here in that lower screening uptake and wider inequalities. And what we've also looked to do on here, you can see that there's some, so yeah, so we've got the four bright dots are for our ICBs in the most recent time period, or cancer alliances, I should say. The grey dots are for all other cancer alliances in England. And then what we've got are some paler dots, and those are the values from a year ago. So this would be 2021 in August. So that would allow you just to kind of provide a bit of a sense of what the direction of travel is. So for Humber, Coast and Vale, it provides that sense that yes, improvement performance is going up, but inequalities are also, it's moving towards this wider inequalities quadrant here, which we could see from that general trend there as well. So the aim of that is just to kind of provide a bit of a time series view in this quadrant as well. What we were hoping to do was to be able to kind of toggle along the bottom to kind of select multiple time periods, but unfortunately our skills ran out at that point. So what I'm doing, I'll just very quickly, conscious of time, but I'll just share you one more screen. So this is for a different metric, but I thought this would just be quite interesting as well to show how we've looked to also other views of the data. So this is a different report, different data. So don't try and kind of draw comparisons to what we were just showing, but just to kind of give a sense of some of the other ways that we've been presenting the data. So this is a very different metric looking at patients with CVD, patients with cholesterol whose cholesterol was well managed in the past 12 months. So what we've got again is our 4 ICBs in England, and what we do on this chart is just display the overall value. So that's the red dot, along with the most deprived patients in the blue dot and the least deprived in the yellow. So what that allows you to do quite quickly on a chart is see how do they all compare overall, and also what are the gaps like between the different systems. So this is, it's not as robust a methodology as the slope index, which takes into account all quintiles, but for people who maybe we found when particularly presenting this to kind of non-technical data audiences, this is a bit easier to grasp than trying to explain the slope index calculations and put them on a chart. And then what we can also do is kind of display them again, so the least deprived overall, most, and put that onto a time series chart for our 4 ICBs. So then that kind of, rather than, as we did before, just showing the overall slope index value, actually just gives people a sense of what's kind of, how is it changing for everyone. Again, not quite as robust, but just in terms of illustrating the, it kind of, I think it's a bit easier to interpret than the slope index if you're not that familiar with it already. And then finally, what we also do, so another good thing about R is it allows you to produce maps. So for in the UK, we've got what we call primary care networks, which are groups of GP practices. So what we do is and so this is our region here, we plot the location of the PCN in the largest practice, and then we just shade them according to their performance. So the ones who are doing worst are the dark red, the ones who are doing best are the dark green. And what this would allow you to do is, and then we also put them into deciles regionally. Oops, that's not really worked. And then also, take my word for it, at an ICB level as well. So when I was talking earlier about what we share with ICBs, this would be, say, the type of additional analysis we share, but that would allow them to look at PCNs who are performing particularly well or particularly poorly. What we've also got is quite a nice, so if you say click on one, it gives you information. We have this table underneath that allows you to then paste that in. And what that then does is show you the values for all of the GP practices within that PCN, and to kind of see which ones might be doing particularly well or not as well. Then we also have information on IMD weighting, so a higher weighting equals higher inequalities, to just try and bring some of that information through. Hope this works. It has done. So then what we also then do is plot all GP practices in our region on a scatter plot. So we have their treatment target or performance on this axis, their IMD score along here. And if you were, say, interested in Humber and North Yorkshire again, what you should do is filter on them. And this would allow you to quite quickly identify practices in areas of higher deprivation who have lower values or lower treatment to target. So if you gave this to an ICB, they could quite quickly use this to say, okay, if we want to drive up performance with this metric and narrow inequalities, these are the specific practices that you might want to link in with most closely. Cool. So I think that is everything from me. So I'm not quite sure if you can stop sharing my screen.
Yeah.
Cool.
Thanks.
I know it's there. Stop share.
Thanks so much, Will, and really, really fascinating to see these data. And also, I really appreciate 2 or 3 things. One is the ability to look at it at different viewpoints. So you had the overall, your comparison across the 3 different ICBs, as you mentioned, and then looking at the trend over time, which I think was really brilliant, but then taking it to the practice level within those ICBs. And I think in Ontario, that's still a bit of a theoretical constraint. We can do it, and we do have the data linkages to link back to GP practices, family, we call them primary care physicians, or potentially in the future also nurse practitioner rosters, to look at which individual providers we are seeing those differences, and which providers are facing the greatest challenges from a primary care perspective. I really appreciate it. And that really highlights, I think, that founding in primary care that we see in the UK and the NHS. But also really appreciate your highlighting that while you saw in Humber Coast and Vale that they actually had radically improved their breast cancer screening rates, that most of it came from that the areas of low deprivation or high socioeconomic status. And in fact, I think the number was something around, they went from a 10% inequality to a 20% inequality. So really exacerbating that inequality of access to breast cancer screening. I thought highlighting that where they made the improvements, it was an inequitable achievement. So that was, I think, really quite powerful in both of those. We're also getting at a little bit of a couple of questions in. Might actually have a question for you in the UK. So we actually, and I've got in the background here another side of people look, every OHT in Ontario has they have their own what we call the Collaborative Quality Improvement Plan indicators, or CQIP indicators. And every OHT has received a PowerPoint presentation that shows the gradient of their indicators by material deprivation. And I just looked at breast cancer screening, and across all of Ontario, on our report, it shows it as, I think, 43% in the area of lowest deprivation and 53% screening rates in the area of highest deprivation. That's either a 20% or a 10 percentage point difference that we see in Ontario. In the UK, what kinds of things, there's a lot of chat about what kinds of things might be driving that. So let me just, and that might be a lead into, John might come back to that later when he talks. But Will, do you, in your conversations with the ICBs, and they see these gradients, what kinds of topics come up when it comes to, as an example, cancer screening rates?
Yeah, it's a good question, Walter. I guess as an analyst, I am slightly removed from those conversations. So I'm not the best place to advise, but I guess it's kind of advertising what's available, actively outreaching communities who are more traditionally hard to reach. There's kind of a lot of initiatives, it feels, that can be done, but I guess it's targeting patients who are traditionally maybe aren't as likely to come forward. So it's maybe an acceptance that you're putting more resource. It's kind of, I guess, not what people would see as low-hanging fruit. Maybe that Humber Coast and Vale example was by targeting patients that for a variety of reasons would be easier to target. So it's almost, yeah, those conversations about how you reach those the traditionally more challenging, very similar to conversations around, say, COVID vaccines or other kind of big public health outreach initiatives, and how you, reach different groups.
Yeah, and I think it's also very much, and I'm really happy to see the chat popping totally quite alive now. I'm gonna have trouble keeping up entirely. That there may be different causes for different indicators, right? And I think having those conversations with local populations, finding those geographic areas where we do see it, and then thinking about the people who live there and having local conversations, I think can be really, really important. I wonder if, and I know this is going to come up a little bit today, and John's got some good insights about how that interface. Do you have a sense, and I think there's some questions coming about when people are able to use the information? I know, Will, you said you provide the data, not so much part about the use conversation, but do you have a sense of, have you heard stories back of when people have been able to use the data? And this will be, John, keep in mind, John Ford, this question for you too, of an example of where we see and what enables people to actually have a good conversation that this data becomes useful. So first to Will, I'll come back to that with John.
Yeah, then very good question. Well, I think, so for, say, for example, for some data we shared it with South Yorkshire ICB, and they have specific nurse outreach teams and people who are using it to create projects. So, I mean, I think NHS, as I guess a lot of healthcare systems is quite bureaucratic, probably bureaucratic, or lots of levels to it. So our level, what we're trying to do is essentially do as much of the legwork for the people who at that more granular level will be doing the outreach, and actually will be able to access GP systems directly to do further analysis. So to actually really identify cohorts of patients. There's different levels. We've got access to a certain level. We try and identify the practices, maybe to focus on, kind of highlight the high level ICB level inequalities. And then it's those within the ICB who've got access to that more granular data, have those connections built up already by working closely with the practices that are now currently in the process of taking that forward. But if they can see that data, see that approach, then it just means that different levels are all hopefully working the same. So obviously in a kind of system as big as the NHS, there's a big risk of silo working and people doing things differently. So it's trying to get different levels working as kind of harmoniously as possible.
Yeah, that's amazing. And I think also the opportunity to learn from each other's practices. And so one of the things maybe in Ontario, as we're advancing this work, for us to try and capture those lessons and share them back and forth. There's a strong encouragement for having this data. What you're talking about there, Will, I would refer to as practice facilitation, to have the people with that transfer of data at the local level in working to support their practices. I want to just thank you so much. Really strong encouragement and supports. I have this question too. The last question I'll put to you is, how do you decide what you've made kind of more publicly available that people might I don't know, somehow implies a bit of reporting on them versus what you just make sort of behind the firewall access to data. Do you know how those decisions are made in the NHS around like what is more public versus what is more private? And I think that was, I'm just looking back to who that question, but Marnie Weber, I think, asked this. Do they have a framework for what data is shared publicly or not? You might have a last question about that.
Yeah, really good question. Essentially, I don't think there is one really. It's all a bit random, and how stuff does get in the public domain and what does. I don't quite know all the different levers that take place. But say recently with CVD data, there's been what's called a CVD prevent audit for the first time that's published a raft of CVD indicators around kind of secondary prevention, so management in primary care, and breaking those down by age, ethnicity, deprivation. So that allows us to do this much more insightful analysis with, but previously, so that's now in the public domain, but previously we as NHS analysts didn't have access to that data. So I don't quite know what happened in the background. I guess it's something becomes a priority area, possibly at a ministerial level or kind of Department of Health, and then that kind of filters down. But yeah, I'd like to say it's all very well thought through and organized, but I'm not sure. It does feel slightly random to me anyway, a bit more on the ground.
I appreciate your frankness and your honesty, Will, and I really appreciate, and many people here also being very appreciative of seeing these examples of what can be done, and how we can make these data more accessible and more useful. Really appreciate your examples. Maybe I'll turn it now over to John to lead the next section here. And John, we really have done a lot of work in this translating of the DECD, and so you heard some of those questions, and so I really look to your insights on what you can share. I think it's a perfect segue into what you have to share with us today.
Great, thanks, Walter. So delighted to be here. So just for a bit of context, so I'm medically trained. I work primarily as a academic public health doctor. So I lead a program of research around health equity at Queen Mary University, but I also work as a public health doctor within the NHS England. And I've worked at various levels within the NHS. So I led on health inequalities within a local health system of about 1 million people. I've also worked regionally across about 6 million people, and I now work nationally across the whole of England. So I've got a bit of experience of working all different levels of the NHS, and also trying to implement evidence-based, data-driven approaches to health inequalities. And for the next 10 minutes or so, I was just going to provide a few reflections on, it's great having all this data, but how do we translate that into what's meaningful? Paul, if you could just go back a slide. So just to start with a positive story, Walter and Will were talking about examples. So one of the really positive examples we've had in the UK over the past 2 years is around COVID vaccinations. So when we first rolled out COVID-19 vaccination programs, it became really clear early on, just through looking at the data, that there was big disparities in terms of who was receiving the vaccinations, and particularly minority ethnic groups, which were much lower uptake of COVID-19 vaccines. And actually that triggered a whole program of work across the NHS to take a totally different approach to how we increase vaccination rates across minority ethnic groups. And so instead of having top-down national publicity campaigns, it switched very rapidly to a much more community engagement, community-led, worked a lot with local mosques, community leaders to try and improve vaccine uptakes for minority ethnic groups. And we saw in the data within a few months a much more equitable picture around how COVID vaccines were distributed. So it's a really positive story of how we had data that informed direct action. I just want to start off positively. And then, so the purpose of this talk is really to give a few reflections on actually I guess my learning from trying to influence data-driven approaches to inequalities in the NHS. So if you go on to the next slide. So one of the big problems we have is trying to build consensus on inequalities. So while across the NHS we have a standard definition of health inequalities, which talks about unfair and avoidable differences between or across groups, and there might be differences you might understand as health inequity, but we generally use the term health inequalities. Well, we can agree that broad definition, actually what that means in practice means lots of different things to different people. So for some people it's about rich and poor, socioeconomic status. For other people it's about ethnicity or race. For other people still it's about age, gender and sexuality. For other people it's about inclusion health groups, so the most vulnerable people in society. This provides a real challenge for us making progress, because actually if it means lots of different things to different people, then trying to make progress in terms of agreeing where we want to get to and what data we want to be using to inform action becomes quite tricky. So if you go into the next slide, and it comes down to this real problem, I think, which we have in NHS, is that the term health inequalities is really good at bringing people together as a rallying call, as an aspiration for everyone who wants to build a fairer, more inclusive society. And so we have lots of traction around health inequalities. The difficulty is when we try and operationalize both the data, the policy, the practice to follow that up. And so that means that we have lots of challenges in translating them, the aspirations, into reality. And certainly from my perspective, I see health inequalities being used in lots of different ways. So the term health inequalities is used in the classical way of this gap and gradient stuff, which we've seen from Jessica and Will. But actually it overlaps into this whole area of clinical variations, so just the differences in performance between healthcare organizations, and also into the kind of parity of esteem issue around does physical health and mental health get treated the same? Does end-of-life care for people with dementia get treated the same as end-of-life care for people with cancer, for example? And there's a risk that that inequalities just means everything to everyone. So, you know, if we don't try and tease some of these apart, in my experience, then inequalities just becomes everything, and everyone argues that everything's an inequality. And so certainly what we've tried to do is to try and tease these apart as much as possible. And undoubtedly there's some overlap in that some clinical variation is driven by socioeconomic factors. So we've got areas in England which are in very disadvantaged areas, struggle to recruit healthcare staff. That leads to some clinical variation. We've got parity esteem issues where some conditions are better funded than others. So, you know, we can, there's lots of charity funding for cancer care, not much charity funding for alcohol and drug teams within hospitals. So undoubtedly there's overlap between these. But we do try, so in my experience, it's much better if we try and pull apart some of these concepts so we can have a laser focus on what we're trying to shift. So if we move on to the next slide. So in terms of moving on to what this means for data and metrics, you know, my experience, if we haven't been able to try and build consensus and clarity in what we're trying to achieve and what we mean by health inequalities, it becomes much harder to try and identify metrics. And the metrics require quite a lot of skill. So Will is brilliant, and what Will is described is quite advanced. My experience is most analysts within the NHS aren't nearly as good as Will in terms of understanding equity analysis. And so, while a lot of NHS analysts are very good at monitoring activity and measuring activity, such as hospital admissions or appointments, actually taking an equity perspective is a whole different kettle of fish. So, you know, it does incorporate new analytical methods with a slope index of inequality. For example, it includes like having to acknowledge things like age and sex standardization. So it requires a good bit of upskilling of NHS analysts. And And then there's a series of decisions to be made, which require quite a lot of time and effort. So do we look at the gap or the gradient? Do we look at national quintiles or local quintiles? I know these are some of the discussions which you have in Canada as well. There's all these series of decisions which need made just for us to arrive at the right metrics. So if we go on to the next slide, one of the things that's sprung up quite a lot is dashboards. In the NHS, we have a lot of data dashboards. A lot of them have inequalities data on them. They vary from publicly available dashboards where anyone can go along and play around with data, to dashboards which are behind 2 or 3 walls of logins and are very difficult to access. The dashboards have mixed success, to be honest. Some of the dashboards which are the best are the ones which are able to tell a narrative, tell a story. Some of them take quite a lot of effort and are really designed for people with analytical background or some kind of quantitative training to be able to interrogate them. And not many of them go the next step to try and link between what the data suggests and what to do about it. So most of them stop at the point of describing the data rather than describing what to do about it. So in terms of what's worked best, if you go to the next slide, Paul, I've just got a few different examples of when I've seen inequalities data working best. So first of all is when there can be consensus on the health inequalities priorities. So when the strategic priorities are aligned and health metrics follow, actually that tends to be more effective rather than what I've sometimes seen is when there's so many health inequalities metrics that it's difficult to see the wood for the trees. Secondly, short, medium, long-term metrics. So actually, I've had this experience multiple times of starting off presentations to NHS colleagues, talking about inequalities in life expectancy and seeing a glazed appearance come on people's faces because they think, what can I do to address life expectancy differences? So actually starting with the short and medium term metrics to say, actually, here are the inequalities in primary care appointments, or here's the inequalities in the distribution of primary care workforce, and linking that with the medium and long term metrics, which we're ultimately trying to shift. Next thing is how we embed key metrics in performance reports. Again, trying to make that link between the data which appears in dashboards and how that gets embedded into routine business. And again, some of the big success we've had, especially locally and regionally, is getting equity metrics routinely reported within monthly performance reports, rather than being I guess a side piece or a side report. We've also been really pushing hard at the minute to try and get all data presented by socioeconomic status and ethnicity as a routine. So that would mean all metrics which are reported at the minute within the National Primary Care Team would be reported by socioeconomic status and ethnicity, with stop and start criteria. So reported by socioeconomic status and ethnicity doesn't always work. If you've got areas which are very homogeneous, so there's not much variation in socioeconomic status, it doesn't work particularly well. Or if you try and do SOAP indexes of inequalities using national deciles, but actually there's only a smattering of for example, GP practices in a certain area with certain socioeconomic status, then actually the SOAP index of inequality can be all over the place. So actually there needs to be some care in terms of presenting data by socioeconomic status and ethnicity, but actually having a by default policy is what we're trying to work towards. We found peer support really helpful. One thing we've got is our community or NHS analysts, which we'll be aware of. But actually having that peer learning so that analysts, and especially around health equity, can share both best practice but also the nitty-gritty code which is needed to run some of these analyses has been helpful. And also this understanding of what the organizational responsibilities are in each of the systems has been helpful. My example is that we try and aim for chicken dinner rather than chicken soup. So chicken dinner being that there's different parts to chicken dinner, which is a roast chicken, roast potatoes, some veg, and some gravy, and it works all together nicely when they're all separate and everyone understands what each part of the meal is doing. Actually, it doesn't really work if we mix them all up. And so through organizational responsibilities, it works a lot better if we understand actually what the role of different parts of the system are in terms of producing the data, generating evidence, translating that, and policy action. Other thing we've tried to do is try and present the data at the level of action. So again, there's little point of presenting national data if we're wanting local hospitals to take action on it. So we need to understand, who are we trying to get to act on this data, and how do we present data at that right level so that they can action that rather than being one step removed from where they're at. We've also tried to work to integrate both quantitative and qualitative data. I've been in several NHS meetings where it can be one or two anecdotes, particularly from clinicians, which can change the whole directions of conversations, both positively and negatively. And so how we try and integrate both the quantitative data, but also the lived experience, and I guess that kind of clinical anecdote as well, is something we're trying to do more and more of. And then this whole, how do we link data with evidence-based actions? The NHS has tried a few times to do this through kind of menus of interventions, evidence-based interventions. And they do work well when you can link in the describing the problem with what to do about it. But trying to do this is difficult. And then finally, again, we've seen a few examples of the NHS when we've tried to link data and dashboards specifically with quality improvement. So it's been framed as a quality improvement program with the idea that people are using data and metrics for equity-focused quality improvement rather than purely to describe the problem or try and inform specific policy decisions. So framing within quality improvement has been useful as well. So I'll stop there. I hope that's been a helpful set of reflections with NHS and equity.
Oh, thanks so much, John. I think for and I really I like that list, and I'm going to be hold off that next poll. And actually, I was listening to you, and I'm like, wow, these are some really excellent practices, and I really appreciate you're taking the time to think through this list with us. And I think it responds a lot to some of the other questions of, what enables or what helps to activate the use of the data. And I think would you agree that if it lines up with some of these areas, these are really the action of the data come from these priorities?
Yes, yeah. And I guess I've got frustrated over the years of sometimes doing really great analytical pieces and having brilliant data and just sitting on the shelf somewhere. And it's how we translate them and try and get policy practitioners to align with with data-driven approaches is not easy, and it's not a given by any stretch.
Yeah, and so just when you're doing it, the team's going to have to watch for this now. I created a new poll for us here to actually come to our audience with this set of things. So no, not this one, but if my team could bring up, if you're watching the poll set, you should be able to see something that says new poll to try. Yes, awesome. If you could post this poll, I want to know in Ontario, how many of these practices, and so if you scroll to the bottom, everyone should be answering this. If you scroll to the bottom, it will be on the, maybe for the slides in the background, Paul, you can just leave John's list. It's not in the slides, just leave John's list, because it's based on John's list. Okay, there. And so if people here could go in and say, which ones of these do you do? And if we're not doing them, there's a note down on the bottom that says none of these are activated well. So I'm interested in knowing which ones of these you think are enacted at all. And I don't need to know, they're brilliant, we're amazing at it, but which ones do you think do you see us acting on in Ontario? So this is like a live, given John's input there, it'd be interesting to see which ones of these we do see enacted in Ontario. So let's just give this up, have anybody go through, look forward to anything you've seen. Do you see consensus on the priorities? Do you see in your local area or ways that have advanced the conversation, identifying short, medium, and long-term metrics, incorporating these metrics into routine performance reporting? So as I'd said, HSPN, we've provided everybody with key metrics according to socioeconomic status and by equity, but these have been fairly static. For most people, they haven't seen a new result in a little over a year since we released the last set of CEQUIP indicators last winter, 2022, and our original set of data went out in 2021. We'll be reproducing these this summer and spring, and part of our thinking is like, how should we represent equity in these reports, which is part of today's webinar in our understanding here. Okay, so please keep commenting in. I'll leave this open. We have about half of the respondents so far. It's a bit of a list to look through, so do look through the list, and waiting to see a few more people having responded in. I'd like to get beyond our halfway point. And wonderful thing today, we often have a lot of, some drop off after the 1 hour mark as people sometimes get on to other meetings for the afternoon. We've really held on to our audience today, and people are still actively participating in today's event. So I think it just really speaks to the importance of this topic. And I'll say to our participants today, engaging, really appreciate your interest and the priority that you are putting on improving equity in Ontario. And interesting, Catherine Isaacs talking about how this, the data that we started to produce during the COVID pandemic on vaccination access, on uptake, on actually even the prevalence and where we were seeing COVID really started to highlight this. Some of us doing the research in the background, it was not a big surprise, but for much of the population and the public, it became so much more apparent. Okay, why don't we share out these results now? Thanks very much, Nusrat and Paul and Tricia in the background here, helping make sure that we get these polls out. So we're seeing, a lot of these are being activated, and hopefully, John, you can see these results on your screen too, to some extent. About a third of people coming in and saying that we link data with evidence-based actions. That's brilliant to see. Integrating quantitative and qualitative evidence, that's brilliant to see. And I think, to a lesser extent, but still somewhat consensus on the equity priorities at your local level, and incorporating metrics into routine metrics, again, a little lower, but also being done. About a third of people are saying that none of these are actively activated well, but to me, I say that means 2/3 mean at least one of these is being activated well. So I think it's a place to be starting from. So appreciate that, and really appreciate the list of targets for us to aim at being 100% on, John. So thanks for that to shoot for. And so just happy if people have other questions for any of our speakers today, and having from Jessica on the measurement piece, from Will on the presentations, and John on this action-oriented agenda. If you have any of these questions, be really pleased. Catherine noting that in Canada, we have a hard time presenting individual level. So for example, at the primary care level or GP level, to be able to look at both socioeconomic status, but also ethnicity. It's very important in Canada. And I know that we were able to do, I have a paper with some people from the Health Foundation where we were able to look in England at, it was a study looking at mortality differences according to according to ethnicity and multi-morbidity, actually, and seeing some differences there. So in the UK, you have some really great opportunities to look at ethnicity at the practice level because it's part of your GP record. I think that's really great. So if these, interested in some of the comments for people to think about, what resources do you have to support measurement of equity in your Ontario Health team, and interested in understanding if you have any other questions here coming in for our speakers. This is a great opportunity, and even, Catherine Isaacs talking about the United States doing a better job tracking health data by ethnicity. To some extent, I'm actually speaking to you today from Seattle Tacoma Airport. I've just been at the United States Health Services Research Conference, which had an equity emphasis in some of the presentations and talks. And I'd say that for Black and Latinx differences, we actually see much better data collection and reporting in the United States, but there's still considerable gaps. But definitely we are behind in Canada. We seem to try to brush things under the, we say we're an egalitarian society, and then we brush things under the carpet when we actually want to take and see the data. So I think having people come and show us data and see it and have a conversation about it is really, really, really useful, very, very important. And I think I would, I'd say, maybe we can go to our fifth poll around the knowledge of our participants today. Yeah, let's go to this one, and maybe we can bring this poll up and have people respond in. Maria, James Shire, I'm going to say Shire, thinking about the ABCD, the action orientation, and I think that action-based community development, that might be what ABCD stands for. I know we have, I saw something coming up this in the near future around IFIC Canada supporting some an event with Cormac Russell, who does a lot of community-based development and around this area. So yes, we do have, Wendy, thanks for noting that CELUS and CHC's use. I know I work in a health system that has EPIC, and there is a capability of collecting sociodemographic and socioeconomic variables. I don't see it actually being used, and I think we're still hesitant on the data collection. Let's keep this open for another minute. People can poll in about their level of knowledge. And really, I'll try and remember as best I can what the poll results were at the start of today. But we will actually be able, when we post these, to be able to put it up end to end from the same sets of participants. So maybe we could, and some people have, there are more people participating that haven't responded to this poll yet. So I'm just waiting to get, we're past halfway, but people could maybe engage in. We'll give it another few seconds, and then maybe we can push this out. And I think we've seen a little bit of a shift, not a massive shift, and I guess over the course of an hour we can expect somewhat, but I think that we had more people in the we can end and post this now. Prior to today's event, we had more people in the 1s, 2s, and 3s, and we see now that we have more people. I think we have about 75% of our audience and participants are now in that somewhat to the higher end of knowledge. So I think we've increased the knowledge somewhat today, which is our main point, is to have the discussion, increase our opportunities for improvement and our knowledge sharing today. I think that these are really great opportunities. And we have more. We have one more event coming up related in our equity series. This is the 4th in our series on equity so far. And we're going to revisit this over and over again. It is a priority, but the 4th Tuesday of the month, inviting everybody to continue to join us. On July 25th, we're moving into our last one, which is what do we do? What are OHTs doing about this? We also have examples, another example coming to us from the United Kingdom, but also we're super interested. We're going to have some examples of what Ontario health teams are doing to improve health equity in Ontario. And I think that's really an essential component of what we're doing here. Huge thanks to our participants today for engaging in this conversation. It's been brilliant. The chat has been super alive with everybody engaging. Our guests have really brought us some new insights. Jessica, on the hard questions of how do we measure this work? Please, you'll see this QR code, open it up here and have and I think we'll also be posting the link in the chat. No, come back to that QR code so people can see it there. Thanks. And leave that open for a little bit so people have the opportunity. We're very interested both in your thoughts on today's event, but also on your suggestions for future events. We run these on the 4th Tuesday of every month. We had a remarkably high proportion of new participants today. 40% of our participants were new today, which is rarely above a quarter or a third. So this topic has, I think, piqued new individuals. Great conversations. Thank you for the informative parts. Really appreciate, John Ford, your sharing how we're enabling and raising the bar for us and our challenges of how we make sure that we're addressing equity in our work in Ontario and how we make sure that data informs our work. Thanks so much, Will, for sharing your experience and expertise and your really, really clear communication about how data can be shared in a way that makes it meaningful and helps us to interpret what's happening. Really, really great information there. And also Jessica for having shared out. And we're going to have some reports coming out. There's a little bit of a series. One of them is on how should we measure equity. So that was a little bit of a preview and some clear interpretations around this work. Really fantastic today. Maybe we could just bring up Jessica, John, Will, Paul, come on screen for a moment. We can take down this piece and we can just say goodbye to everybody. And hopefully I didn't cut out too much. Thank you very much for joining us all today. It's been an excellent opportunity. Take care and have a lovely afternoon wherever you may be.
Great, thank you.
Thanks, Walter. Cheers.